Good morning, everyone. Welcome to Pediatric Grand Round. Thank you for joining us today. If you are anywhere near the Tanglewood Complex, we are here, bright and very pleasant, and we would love to see you come in person. We do have snacks and coffee. That's an incentive for you. All right, so today's speaker is Dr. Jackie Price, formerly Dr. Jackie Gilman, for those of us who are confused like myself. She's one of our third-year pediatric residents here at Virginia Tech. She completed her undergraduate studies at Virginia Tech in human nutrition, food, and exercise. She then attended Edward Weir College of Osteopathic Medicine, where she graduated in 2020. She will be staying here at Carilion as a general pediatrician at our Daleville Pediatric office. During her time here, she served on the Program Evaluation Committee, numerous educational activities, and completed her QI project on nursing resident communication on the inpatient services. Please join me in welcoming Dr. Jackie Price.
Good morning, everybody. So like Dr. Plummer said, I'm Dr. Jackie Price. I'm talking to you guys today about the pediatric athlete, concussion testing, return to play, and future practices. My faculty advisor for this was Dr. Prusakowski, one of the ER physicians in the peds realm. So with that, we'll go ahead and get started. So objectives here. We're going to review definition of concussion and how to diagnose concussion, compare sideline concussion testing and concussion testing for the primary care office, discuss return to play criteria and most recent guidelines, and then explore current research for future testing and diagnosis of concussions. I have no financial disclosures. Throughout this PowerPoint, you will see lots of Virginia Tech photos, some sports photos of my bonus son, and then I think I threw in a couple of Dr. Prusakowski's kiddos in there too. So enjoy the sports world. All right, so why are concussions important? Why do we need to talk about this, and why is this relevant to you? So this is kind of a rough number. There's multiple different numbers everywhere you look, but significant number, greater than 3.8 million recreational and sports-related concussions per year, and that number is not including our non-sports-related concussions. And then of those sports-related concussions, we have about 1.1 to 1.9 million of those are less than 18 years old. So that's almost half of those concussions are just our pediatric population alone. That doesn't include our college kids either, which I don't know if you guys do, but I still consider them little kids. They're all still growing and learning, so those are also not considered in this 1.1 to 1.9 million. Up to 75% of these have been seen in the PCP office, so that's whether they've gone to the ER first and then they've showed up in our PCP office afterwards, or if your primary care office is going to be the first line of defense, you're going to see these kids first before they even go on. And then even more than that, some of these kids don't even realize that they're having concussions, and they come in, they're like, yeah, I kind of bumped my head yesterday, I have a little bit of a headache, but I'm fine, it's whatever. And you're like, well, man, you probably have a concussion. So definitely relevant and things that we'll see pretty often in our pediatric world. So let's talk about some definitions. There is not a great definition for concussions, and as I continue to do my research, there's not one single definition for what is a concussion and how to define that. And I think that's kind of what has caused a lot of trouble in the world of sports medicine, is that they can't come up with a single definition, and there's all these things involved in it. So the American Academy of Neurology defines this as a trauma-induced alteration in mental status that may or may not involve a loss of consciousness. There's different terminology that you may see throughout this PowerPoint that appears multiple times in the research. Concussion versus myotraumatic brain injury, and then also sports-related concussions as well. I think they're trying to move away from the terminology myotraumatic brain injury, just because some of these kids end up having, or even adults end up having, more than just a mild traumatic brain injury. Like, it can progress to even moderate or severe in some of these cases. So that is a little bit of a misnomer when we're talking about these concussions and these kiddos. And that is my bonus son there with his fun hockey sports stuff. He's a little bit obsessed. All right, so talking more about definitions, there was a 2014 systemic review in neurology that attempted to take all the literature out there that fit into their guidelines and was relevant to what they were talking about, and then basically come up with a consensus definition. And what they found is there were 4 very common features that were present in almost all of the, quote, diagnosed concussions. So it's going to be observed and documented disorientation or confusion immediately after the event. You can have impaired balance within 1 day after injury, so a reaction time within 2 days after injury, and then impaired verbal learning and memory within 2 days after injury. So those are probably some of the most common that we've seen in the office and that you'll probably see in the ER as well when you have kids coming in with those concussions. And I think we could all attest to we've probably seen multiple kids like that. So there's a lot of words on this slide, and I'm going to kind of talk through them, and then we'll try to summarize at the end. But like I said, because we don't have a great definition, we also don't have a great understanding of the pathophys. So this is kind of the best definition of what we can figure out as to why we have a concussion and what the pathophysiology is behind it. So we're going to bring it back to med school a little bit here. So you have your injury to the brain, and basically that injury causes potassium to come out of the cell. And then there's also an increase in extracellular glutamate. Glutamate is an excitatory neuron, and that leads to the membrane depolarization or the neuronal depolarization. And that further causes potassium to come out of the cell, and then we also have the calcium and sodium coming back into the cell, which then depolarizes the neuron. Our body, being as awesome as it is, attempts to restore that homeostasis and causes an upregulation of those sodium-potassium ion pumps, which further depletes the intracellular reserve, and then we have to steadily increase our ATP use, and so that causes hyperglycolysis. So now, not only we're having this depolarization, we're having that decrease in glucose because we're having to use so much ATP to work those pumps. Our pediatric and adolescent populations already have been shown to have reduced cerebral blood flow after a sports-related concussion. They've proven that a couple times now. So you have this increased energy demand, and then you also have this decreased blood flow to the brain that then increases that energy crisis even more. So now you've got the double energy crisis. So again, our brain and our body trying to normalize things and be the awesome thing that it is, it increases the intracellular calcium levels, and then the neurons sequester the calcium into the mitochondria. And that leads to mitochondrial dysfunction. And what do we know? Mitochondria is the powerhouse of the cell. So what are we doing? Further depleting that energy demand. So we've got now 3 hits to our energy demand, causing a decrease in the energy and worsening energy crisis. So then our body ramps up the glucose metabolism and basically causes a hypometabolic state that can persist for up to 4 weeks. And that's kind of where some of those symptoms come in. We're essentially in this hypometabolic state and a significant energy crisis. So that was a lot of talking, a lot of things, but essentially what that boils down to is you've got 4 different hits in your body trying to make up for this injury, and you're essentially losing all that energy and coming into that energy crisis, causing this worsening symptoms. So, all right, so going down to physiology of child versus adults. So, you know, all the adult medicine people say, yeah, children are just little adults. We all know that that's not true when it comes to anything. Children are totally different than adults when it comes to anything like that. So initially it was thought that children were really, you know, they're pliable, they bounce back quickly, they're going to have a better recovery when it comes to concussions, traumatic brain injuries, all those things. But this is no longer in favor, at least in regards to our concussions and mild traumatic brain injury. Can't speak as much to our severe traumatic brain injury, but when it comes to concussions, there's a couple things that vary. So we have a different brain water content in our children. There's a different level of myelinization. They're trying to continue to grow and increase their myelinization. Their skull geometry is way different. You know, kids have big heads, suture elasticity, and then neck strength. That one's going to be a huge one that we'll talk about a little bit later. But if you look at a kid and their neck strength compared to what we have, very different. So, but all of these things will play a role in the resistance in the brain, so that shear resistance that you're going to see. And essentially, these concussions have been found to cause an impairment in our working memory function, which is going to be huge for our kids. That's the ability to temporarily store and manipulate information for carrying out a cognitive task. So, you know, you ask your kid, hey, go to brush your teeth, go wash your face, go read your book and go to bed, that kind of thing. And, you know, we can do that, but kids sometimes struggle with that. So when you impair that working memory function even more, you're going to have worsening outcomes for these kiddos who are trying to just live their life and learn a little bit more. So, all right. So we can get away from some of the boring stuff now and talk about a little bit more relevant things. So our high-risk sports. So I have a list here of basically all of our most popular sports, and they've kind of listed them from most to least concussions per 100,000 AEs. And you can see that boys tackle football is right there at the top. And I think that's something that we all kind of already knew. Football is a very dangerous sport, and we see a lot of concussions, especially in the summertime. I know that they come through the ER quite frequently. If you've done an ER rotation in the summer, you see a huge uptick in that. And I'm sure in the PCP office, we also see a pretty big increase in that. And that's followed by girls soccer, boys lacrosse, and boys ice hockey. And of course, my kiddo plays lacrosse and ice hockey, so I'm just waiting for that concussion to happen. But the interesting thing is when they compare girls sports to boys sports, when they're playing the same sport, so like girls soccer, girls basketball, boys basketball, girls actually have an increased risk of getting a concussion compared to boys. There wasn't a whole lot as to why that happens, but it's just something that's been researched, and they've shown that there is a clear discrepancy between girls and boys. But when you compare like football to girls soccer, obviously it's not going to be equal, and there's a little bit of difference. But if you're comparing girls soccer to boys soccer, girls are definitely more at risk. All right, so talking about some clinical manifestations, we can classify these symptoms into 5 different categories. So somatic is going to be your headaches, your nausea, your vomiting, those kind of things. Vestibular is going to be more of that dizziness, fatigue. Your oculomotor, again, is going to be kind of trying to focus on your schoolwork and things are blurring, you can't really focus on the page. Cognitive, it's going to be that fuzzy head, not really being able to complete tasks, that working memory that we talked about before. And then emotional and sleep. So our kids are going to be, they can be angry, they can be emotional, they can be sad, all those things, and then difficulty sleeping as well. I kind of listed here the top 4 symptoms that we really see and how common they are. So headache's going to be your most common, followed by dizziness, difficulty concentrating, and confusion. And then we always have to talk about our red flag symptoms. So that's going to be increased severity of headaches, nausea and vomiting, numbness and tingling, or really any abnormal neurological exam that you're finding, mental confusion, and then slurred speech. So if you see these things coming into your office, or if you're doing sideline care or anything like that, those things you're going to want to send to the ER because they're probably going to need some further imaging and evaluation just based on those symptoms. And I think, at baseline, those things are, when we have any sort of head injury, those are the things that we really look for, especially those abnormal neurological exams. So if you see those, send them on over to the ER, to our friends over there, and so they can check them out and see what's going on. All right, so special consideration, things you want to pay special attention to. So our kiddos who have migraines at baseline or headache disorders already, they're going to be ones that are going to need a little bit of extra attention. Our learning disorders, ADHD, mental health conditions like depression and anxiety, and sleep disorders. So let's talk about why those are so important and such red flags for kiddos with concussions. So we already talked about the symptoms, right? We have headaches, we have dizziness, we have migraines, all those things. If you already have a migraine disorder, that could potentially worsen that and make those symptoms way worse than they already are at baseline. And then we'll talk a little bit more later about how to do return to play. But if somebody already has migraines at baseline, how are you supposed to decide if that kid can go back to play? Because they already have migraines and they're continuing to have migraines, and those are also the same symptoms. So things you want to consider. And then, of course, our ADHD kids. They are very impulsive and very energetic. So they are the ones who are going to actually be more at risk of getting concussions. They can be really impulsive on that field. They can be really impulsive in practice. Like, hey, coach is saying do this and this and this, and they're over there hitting their head on the side of those things you push in football. So, I mean, they're definitely more at risk, and they can have worsening emotional lability and worsening impulsiveness as they're recovering from concussions. These kiddos are actually ones that may benefit from referring out to some concussion specialists to help with recovery for them. And then this one, I think we need to continue to reiterate in our offices. Loss of consciousness does not necessarily predict severity. More so the nature of the injury, the burden on the athlete, and then the duration of those post-concussive symptoms are going to determine more the severity of, and how long these concussions are going to last. So the concussion, You have some kids who come in and they've lost consciousness for 15 minutes, they're out of it, they come back to you and they're like, hey, I feel great. And then those kids don't have any symptoms for 14 days. Like, those kids may not necessarily have a concussion, but we have some kids who do have that rebound where after 5-7 days, they're like, oh man, these concussion symptoms are actually coming back. And those are high-risk kids that we're going to want to refer out to. So this is more, I think, for our general pediatricians and our residents, but talking about that pre-sports participation. So I think we have all, whether or not in residency or now as a PCP, even GI docs in their residency had to do a pre-sports participation physical at some point. But our schools typically require these from the PCP. It's important to delve into previous concussion history. So like I said earlier, like, you have those kids who come in like, yeah, I hit my head and I had a headache, and they don't realize it's a concussion. So it's important to delve into that and ask these kids, like, yeah, have you ever hit your head before? Did you have a prolonged headache? Did you have any nausea and vomiting? Just to make sure that we're covering all our bases here. And then it's also important to ask about those length of symptoms. So if you have a kid who comes in who previously had a concussion and their symptoms lasted for 2 months, those kids are at huge risk for getting another concussion, but also having prolonged symptoms again. So they're going to be ones that you may talk a little bit more about. How are we going to prevent concussions? What are the safety features that we're going to put in place to prevent these concussions in the future? So those are all very important. And then again, we'll touch on baseline testing a little bit later, but those can be really helpful in diagnosing concussions and when to return to play in the future, especially in our special consideration kiddos that we were talking about before. And then again, reiterating to parents that just because a child just loss of consciousness is not the only sign of concussion. There are lots of other signs that are there that can mean concussion that aren't just necessarily loss of consciousness. I think that's a little bit of an old wives' tale that some of our parents still think about. So it's just important to educate and make sure that they're aware of it. All right, so let's talk about baseline testing. So this is kind of the best testing that we have right now for diagnosing a concussion and really talking about return to play. There's 2 different tests that have kind of been the popular research testing. So that's going to be your SCAT-5 testing and your impact testing. These are often performed by a school's athletic trainer or team doctors. I think some of our high schools are lucky enough, especially more so in Blacksburg. I'm not sure about the ones here, but they all have team doctors from the Virginia Tech Sports Medicine, and I think a few of them here that actually help with some of this testing. You have to be trained in this. I think you just do like an online video training. Doesn't take super long. And then this baseline testing itself is helpful for evaluating the severity of concussion. And like I said earlier, this is going to be extremely helpful in your kids with migraines, ADHD, and other comorbidities because it gives you a good baseline for what their baseline symptoms are. So if they at baseline have headaches and they're at 5, and then they have a concussion, and then they're all of a sudden saying their headaches are 15, you know that that kid is not back to their baseline migraine level. So that's going to be something that you're really going to want to look at. And again, like I said, this would be a good person that you could probably refer out because they have a little bit more time to do this testing. So sideline testing. So always the ABCs first. Whether or not you're a trained team doctor, athletic trainer, or just a parent who is on the sideline who happens to be in the position there, because it very well could happen. I know I've already been asked several times to evaluate children. I'm like, oh my gosh, I'm just a resident, I can't do this yet. So, but always you want to check your ABCs first. So airway, breathing, circulation. And then especially in these head injuries, cervical spine is going to be huge, especially if they're like lost consciousness, can't tell you if they're in pain. You're going to want to protect that cervical spine and make sure that there's no injuries there before you move that patient. Evaluation, ideally by a medically trained professional. Hopefully no like random person off the street is running out there, but sometimes it happens. You just can't always control that. So. And then if you're able to, you want to take that patient to a quiet area, so a locker room, if you've got a tent there, away from all the chaos of the sports that are happening, because those boys are going to want to look and see, oh, did they make the tackle? What's going on? So taking them away from that distraction so that you can really do these baseline and sideline concussion testing. And then the SCAT-5 that I just briefly touched on has its own sideline testing that is able to be used. The SCAT-5 or the child's SCAT-5 has like a 10 to 15 minute sideline test that a lot of our athletic trainers will use to decide, can this child go back to play or do they need to sit out and go see a medical professional? I think we've kind of moved away from sending them back into play, at least in our lower, like middle school sports and maybe even the high school sports. I think everybody's a little bit more conservative with that. I can't speak to the college sports because, you know, they're professional. That's their career. But again, usually if our kids have a questionable injury, they're taken out for the remainder of the game for the most part. All right. So let's talk a little bit about SCAT and impact testing. These are really the ways that we should be assessing our children who have concussions. It's not really the most feasible for our outpatient clinics because they do take a good bit of time. We only have 15-minute appointment slots, so it's very difficult to be able to fit these into there, which is why I have some other resources that we can talk about in a little bit to help with some of this. So SCAT 3 or 5, 3 was the previous one, 5 is the more up-to-date one, and that's your Sport Concussion Assessment Tool 5. If you're older than 13 years old, you can use that SCAT 5. If you're under 12, use the child SCAT 5. We don't have a great amount of evidence. Less than 6, you can kind of push some of this stuff up till 6, but less than 6, you really just, the kids can't tell you their symptoms as well. And, you know, they're those kids who are like, oh, does this hurt? Yes. Does this hurt? Yes. Does this hurt? Yes. Like, you cannot get a straight answer from them, so good luck with that. And then, like I said, the SCAT you can use for sideline testing. It's got that good 10 to 15-minute one that you can use. This one specifically is free to use online, and it's basically, they have an app that you can use and you roll through each individual section. Like I said, it does take a little bit of time. I think I did one just for fun on my stepson, and it took almost 30 minutes to get through it, so it is very time consuming, but it is very helpful in kind of the way that it's practiced now in the sports medicine world. So SCAT has a couple different testing categories. They talk about symptoms, they do some cognitive screening, immediate memory, so that 5-word recall, concentration, they do the digits backwards, the months backwards, you do your whole neurological testing, a balance exam, and then the delayed recall coming back to those 5 words. All right, so impact testing is the other one. This one is FDA approved for children ages 8 to 11. This one specifically has a little iPad app that you can do. It looks like it's almost kind of has some games on there, and you're trying to play memory, and you know, with the cards that we used to flip over, those kind of games. You can have healthcare professional do that, parents, and then the child can actually work the iPad themselves. This one, however, is not free. You do have to pay for this test. They have like a yearly subscription and then an individual like per test subscription as well. But what I thought was really interesting, impact testing specifically had a whole page on how to bill for these tests and use those in your clinical practice. So I won't delve too far into that just because this is not something that we frequently use, but they do have a couple ICD-10 codes here for neurobehavioral status exam and then your neurophysiologic testing evaluation. And that's, if you look over here, this one's for both the testing itself and then test administration and scoring. And you can do it each additional hour, which we don't have an additional hour to usually do these testing, but it's there if you need it. So, and then they have, like I said, that whole website has a whole training video and things like that if this is something that you decide you'd like to do. All right, so let's talk about job as a physician. What is your job in the clinics for these children? So triage. Again, we're looking for those red flag symptoms. If they're presenting to your clinic with those red flag symptoms, you need to know, like, hey, I need to send them to the ER, or hey, I think I need to refer them to our brain injury center for further evaluation. And then talking about paperwork. So, you know, we're all familiar with paperwork. It's just a part of the job. But I'm sure many of you have seen the pre-sports participation paperwork, and then also there's the Virginia sports return to play paperwork as well. So we're going to go through that in just a second here to kind of talk about what Virginia has kind of said is their return to play guidelines that they want us to follow. So talking about returning to play in school. So these have kind of changed a little bit over the past couple of years. I think previously we were saying like, hey, these kids need to rest, they need to lay on the couch, they need to not do anything until those symptoms resolve, and then we can talk about going to do more things. And we've kind of moved away from that a little bit. They're still talking about relative rest for the first 1 to 2 days post-injury, so, you know, not playing on your screen time, not going to school, hanging on the couch with mom while she watches her soap operas and you take a little nap. So that's still kind of the same. But then we kind of want to talk about this staged graduate return to play program. Each of these take about a day to perform. They shouldn't go faster than one step at a time. And it previously was said, like, if you have any symptoms, you need to back up and go back. And now we're kind of leaning away towards, yeah, you can have like a little bit of symptoms if they're tolerable. If they're getting worse, you need to take a step back and go to the previous step. But if they're staying the same and you're able to kind of push through them and medication's okay, then it's okay to kind of stay at that stage before you go on to the next one. So I think everybody's pretty familiar with these, but you're going to want to talk about symptom-limited activities. So just daily activities that don't provoke symptoms, make them worse. The next step is going to be your light aerobic activities. So, some stationary bikes, going on a walk with your dog, those kind of things, just things to increase the heart rate a little bit. And then you're going to start working in some real, like a little bit more intense movement. So that's going to be your running or skating drills, nothing that has a risk of like impact to your head or anything like that. And that's just adding the movement back in. And then you're going to do your non-contact drills. Those are going to be a little bit harder drills. So some passing drills, some drills with the team, nothing again that has head impact, but that's going to work on increasing that coordination, increasing that decision making, and basically adding back in those brain functions and making sure that you're not having worsening symptoms. Then you can move to full contact practice once you've kind of gone through those stages, and then once you've been there, you can go back to normal gameplay. Every kiddo is going to be a little bit different. Some may progress more quickly than others. Typically, 4 weeks is what we expect. Some kids go back in 7. 4 weeks is kind of like the max, and that's where we should be like completely better. Nothing is hurting us anymore. So this is what I was talking about before, the VHSL concussion resources. So it's a whole lot longer sheet, but I just kind of cut out the clearance checklist because I think this is what's a little bit more relevant to what we're talking about today. So this is the paperwork that they give you, and you just check the little boxes, and then at the bottom you'll give your recommendation whether or not they can return. So our symptoms that we already talked about before, no symptoms at rest or with normal activities of daily living. So schoolwork, walking, doing your homework, those kind of things. They need to have a normal neuro exam, normal balance testing, and coordination. So they talk here about the BESS, or I think it's best balance test, and then the 3-meter minimum gait. To do the best balance test, you need like a foam mat, which we definitely, I don't think we have those in the office at all, but you can do the 3-meter tandem gait test, and that's going to be where you basically walk forward, kind of one right in front of the other for 3 meters, and then you do it with your eyes closed, which I don't know that I could do that when I'm not concussed, but just something to think about. And then you go backwards, so you do it backwards, and I think they're actually supposed to have their arms to their side, and then you can close your eyes and do it backwards too. So good luck trying to do that with your kids, but that is what they recommend. Stand by them in case they fall. So, and then a return to baseline or normal neurocognitive testing, which would be that SCAT or the computer-based testing like IMPACT. So they do say a return to baseline, so you can actually go off of this without doing the SCAT or the IMPACT testing. Say like, yeah, they're back to their baseline, they're acting their normal selves, that kind of thing. But realistically, SCAT and IMPACT really should be what we're doing for these kiddos. And then you can mark your recommendations at the bottom, whether or not they are clear to return or if they're still symptomatic and not clear to return to play. All right. We kind of already touched on this earlier. I got a little ahead of myself, but I think it was important to talk about the current guidelines and not the previous guidelines. But basically, like I said, it's not necessarily recommended anymore to have them rest until they're better. That was found to have some pretty detrimental effects, especially to our pediatric population. They had some worsening fatigue, worsening depression, and that deconditioning. So when they did return to sports, they were actually a little bit more at increased risk of injury because they were so deconditioned. Returning to school and social activities within the first couple of days. Like I said, not in a way that's going to aggravate their symptoms even more, kind of keeping it that steady rate and not worsening. And then again, we're keeping it at a tolerable level for the student, and it does not worsen their symptoms or cause reemergence of previously resolved symptoms. So that's going to be a big one. If your kid has moved on to the next stage, they're feeling good, and then all of a sudden they're feeling a little bit dizzy again, that kind of thing. You want to back it up and go back to the next step. It can be a pretty frustrating process for our pediatric athletes because they are very used to go, 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 I am active all the time, I'm participating in all these sports, and hey, now I gotta sit here and limit myself. It can be pretty debilitating to these kiddos. So we just need to be cautious of that and realize that these kids want to get back to play and they're struggling. All right, so talking about our recovery in our adults versus our children, we already said that adults and children are very different. They have different ways of recovering. So children are actually having longer recoveries than adults, a little bit more difficult recoveries. So you and I, well, pediatricians are probably not a good example because we are using our brains pretty frequently for decisions throughout the day, but you have your people who sit at a desk all day who are doing the same thing over and over again. Those kind of things, they're not really learning anything new every day. They know what they're supposed to do, they know what they need to get done. But our kids are constantly working just like we are, but they're also learning new things. They're building new neurons in their brain, they're making new connections, adapting, getting new skills. So like those things are a lot more difficult when you're trying to do that on top of recovering from a concussion. So that is a huge reason why our kids sometimes have those prolonged symptoms that really struggle to come back as well. But what are we supposed to do? Keep them from stop learning? Not really, because then you're going to have them fall behind, and then you fall into more depression and anxiety, and our kids are already super anxious nowadays. School is out of control, those kinds of things. So it makes it very difficult. And then, like I said, they're building those new skills. So the skills that aren't yet well established, when they have a concussion, can actually make those really vulnerable to disruption. So they could have trouble gaining those back, or trouble getting to that point that they should be without like a delay or anything like that. And then they did do a study, this was by Field et al. It compared the recovery of college athletes to high school athletes in football, and it compared high school and college. The high school athletes showed a significantly delayed and protracted recovery rate compared to the college athletes, despite the college athletes already having significant like pre-morbid concussion symptoms, because they've had previously concussions before, but since they're older, not doing as much of that adaptive learning, they had a little bit faster recovery. So just something to think about as we're diagnosing and helping our kiddos come back to play. All right, so let's talk about when to refer our kids. So like I said, most children will resolve within 4 weeks. Ideally, like we would love for them to be back and bouncing back in a week, and a lot of kids do, but some kids really have those prolonged symptoms that go past those 4 weeks. So we already talked about the red flag symptoms. Those need to be referred and sent to the ER ASAP. But literature says that if we're hitting day 10 of symptoms, we should really start referring those kids out and having them start getting tucked in with some people who do this for a living and have a lot of training in how to help these kids recover. And then our kids with structural abnormalities, Chiari malformations, they specifically said like intracranial hematoma evacuations. I don't think anything like hydrocephalus or any sort of like history of brain tumors. Those kids should actually, it's recommended, be referred to neurosurgery prior to return to play to make sure that everything is okay on their part before returning. So just, again, something to think about. I know we don't always do this, but our high-risk kids, we maybe need to pay a little bit more special attention to. So where do we refer these kids to? Great question. Sports medicine is always super helpful. We do have sports medicine in the area. Not every place has sports medicine. I don't think David's little hospital is going to have sports medicine out there, but and then you have your neuropsychologists, and they can help with that psychological aspect as well, helping with that brain function and everything like that. Physical therapy, speech therapy, and occupational therapy are also very helpful in these situations too. They can help a lot with the concussion and helping them get back to their baseline. All right, so we all work at Carilion, so let's talk about some resources that we have here that we can help our kids with. And like I said, I don't have any financial gain in this, but I did spend a good bit of time talking to Dr. Damon Keel, who heads up the Carilion Clinic Brain Injury Center, is kind of helping in that. And he actually said that he would love to come talk to us sometime a little bit more about this and some of his research if anybody was interested. But they're kind of our main referral center here. We have our sports medicine clinic, but they're actually kind of sending those referrals to our brain injury center as well, kind of screening those out. So this is going to be the place that we're going to want to send our kiddos. At the brain injury center, they have a PM&R physician, neurosurgery doctor, they have brain injury medicine psychiatry there. They have our neuropsychologists that we just talked about, speech therapy and physical therapy. So they're going to have all of those in the same building, and essentially what they'll do is they'll bring those kiddos in, kind of screen and see like, okay, what do we need to do to help this kid? And then they just kind of bounce from place to place and get the help that they need from them. So he sent me a little do's and don'ts for referring to the Brain Injury Center. So in order to place it, you just do an ambulatory referral to the Brain Injury Center. I'll show you a screenshot on the next page. You want to make sure that they have a working cell phone number and Epic, which does not always work for our kiddos. So if you're doing this, please make sure that you have a working number in that chart so that they can call them to set up these appointments, because these are a little bit time sensitive, right? You want to get these kids in as soon as possible so that we can get them back to return to play. We no longer want to refer them to neuropsych. We have that built into the Brain Injury Center. So if you do that, usually they'll screen them out and send them to the Brain Injury Center if needed. So just be aware of that. And then never promise them that they'll be seen tomorrow, but I think we all kind of know that nobody's going to be seen tomorrow. But they said to go ahead and put see within 14 days, and usually they'll see them within about 7. Dr. Karen Keel said that she has seen a lot of her patients from the ER get in less than 7 days. So again, we can't make any promises, but if we start referring on day 7, when those symptoms really should be improving and resolving, then by that time that reach this 10-day mark, as long as they're still having symptoms, they're tucked in and should get the care that they need. So just information for you guys. So this is what the ambulatory referral to Brain Injury Center looks like, and lucky for us, it has the criteria here right at the top. If you ever forget and you're like, hey, I want to refer this kid, I don't know if they meet criteria, just pull up a little pop-out window and it tells you right there. So this isn't really pertinent to us. This is more for the ER. I don't think we really should be, unless after the mapping they somehow got missed in the ER, moderate to severe traumatic brain injury, that should all be taken care of in the ER. But this part down here, adult or pediatric patients who have sustained a mild traumatic brain injury with loss of consciousness less than 30 minutes, post-traumatic amnesia less than 24 hours, or this is where we kind of catch all of our pediatric patients who have concussions for prolonged time, GCS 13 to 15, which is most people walking and talking and standing. Symptoms of headache, nausea, vomiting, fatigue, drowsiness, dizziness, or loss of balance for greater than 7 days. So when we reach that 7-day mark, we technically meet the criteria, and they're kind of heading towards those prolonged symptoms. So go ahead and send them. They've got some great nurse practitioners there who are kind of helping screen these out and figure out who needs to be seen sooner, who needs to be seen later. So write a good note, put your little clinical referral reason in there, and they should help get those kids where they need to go. And it sounds like their goal is to actually get some pediatric specific people into their clinic by the fall. They will see pediatric patients. Right now, and everybody there is comfortable seeing peds, but they are working on trying to get a peds specific doctors and psychologists and all those people there for the fall. All right, so let's talk about some long-term outcomes. So not great data on long-term outcomes, especially in our children. We're just, I think, in the past couple of years, really starting to pick up our research on this. But there have been studies that have shown some earlier onset dementia in those who've experienced moderate traumatic brain injury. So that's not all of our kids, right? Because we already said mild traumatic brain injury can be some of them, but some of them can progress as moderate traumatic brain injury. So those are the people who are a little bit more at risk of getting dementia earlier on in life. Social effects, we pull these kids out of school, and they miss their important activities. Academic effects, they fall behind because they can't focus on these things, and then you really are kind of trying to play catch up for a really, really long time. Some of these kids even need like 504s, IEPs, if they're really having prolonged symptoms, because they just need that little bit of extra help to get through the educational portion of school because they are still having these prolonged symptoms. So you may be asked to fill or like help facilitate that in your office. Chronic traumatic encephalopathy, I don't know if you guys have ever seen the movie Concussion, but that's the kind of theorized condition that they're seeing in some of these professional football players. Again, you can't really diagnose it beforehand, but they've done several studies where professional football players have donated their brains essentially to science, and they've seen significantly worse of whatever the criteria is for the chronic traumatic encephalopathy. There's been a few, I hate to say this, but there's been a few high school players who have actually donated their brains to look at this, and theirs have been very mild compared to what the professional players look like, but they are still showing some signs of this, even in our high school football players too. Second impact syndrome, we'll talk about in a second, and then talking about retirement with these kids. So some kids are just really prone to these and are having concussion after concussion after concussion. And sometimes you have to have that important conversation with the parent and the kid, like, hey, is it time to retire this to make sure that you have a good life ahead of you and that you aren't having some of these long-term out effects in your future life. There's not great research about like how many concussions you need to retire, but you know, if you're having these prolonged symptoms and every time you go back to playing sports, it may be a conversation that needs to be had with your patients, and that's going to be a hard conversation. So we try not to do it if we can avoid it, but obviously we want these kids to grow up and be successful adults. So just, again, something to think about for these kiddos. All right, so second impact syndrome. Again, I feel like I'm talking about a lot of theories here. Nobody truly knows what's going on, but second impact syndrome is one of our theorized syndromes. Again, seems to be pretty rare, but this was kind of why we initially were really making these kids rest until they're symptom-free, because we were so scared about this syndrome. But basically, it's when somebody returns to play prior to their brain being completely healed, they get a second injury to that head, so that second impact, that further injures the brain. Essentially, it causes some worsening blood flow, like we said, when you have a concussion, it worsens the blood flow to the brain, causing that energy mismatch, so we said that triple hit that's going on to cause that energy mismatch. And then that leads to pretty rapidly progressing brain edema and often herniation. Most of these result in death because it happens pretty suddenly. So again, it's scary. Like you obviously don't want kids to die. That's never a good thing. So this is just something to be aware of. Again, I said very, very rare. Many studies have been done, and it's an exorbitant amount, and like 2 people have maybe had it. But it is a medical emergency, and this is kind of why we have progressed the way that we have. All right, so let's talk about future directions. What can we do to help our kiddos who have concussions? How can we diagnose these earlier? What can we do to prevent these? There's lots of really promising research out there that's going on right now. A lot of research just in our community. Dr. Damon Keel has been working a lot, and then Virginia Tech Sports Medicine is always working on concussions and how to help with those and prevent those. I know you guys have probably heard about like the Virginia Tech helmet study that they've been doing. They measure the blows to the head and can computerize all those. So we've got a lot going on here. Lots of good things. So we've all seen the funny GIFs and TikTok videos of the people in the gym doing the crazy head exercises, but lo and behold, those exercises may actually be helpful for our kids in concussion testing. So of all the things that we talk about, I think this is going to be the easiest one to implement and could be a good practice to start talking to our patients about. So we said that children are definitely not little adults. So they've got looser ligaments in their neck. They've got looser ligaments everywhere. And they have that decreased neck strength. So those two combined together can put you more at risk for concussion. So they've done a couple studies looking at neck strengthening exercises and seeing how that does at preventing concussions. So what they found is that for every pound of strength added to your neck muscles, there's been a reduction in risk of concussion by 5%. So like that's a pretty good amount. It's a very easy thing to do. You know, you just teach your kids some exercises. You can do just like some passive exercises. You've got those TheraBands. You can always put them around the side of your head and just do some like side things like that. Supermans can even work your neck muscles as well. So these are very easy things that we can be like, hey, you should try these. Make sure that your neck is nice and strong, and we can help prevent some of these concussions as well. And then this one I had found online. This was, I think, FDA approved a couple years ago. There's a patent for it. This is called the Q collar. You can see that she's wearing this here. It goes around your neck. Basically, it provides a compressive force to that internal jugular vein, and it increases the blood flow in the vessels of the brain. Basically creates a little bit of a tighter fit in the brain, making less of that slosh motion when you're hitting things. Brain goes forward, that kind of things. They say it can be worn up to 4 hours. Obviously, they have not really tried it on kids who have like blood clot disorders, seizures, like internal carotid sensitivity, those kind of things. So I mean, this would be more for like your very healthy kid who does not have any other comorbidities. And you know, I don't know that I'd recommend wearing it for more than the game, but it could be good thing to talk about wearing during a game as well. So they did do a prospective longitudinal study, 284 subjects, 13 years or older, who were on high school football teams. 139 wore it and 145 did not. They basically, I believe, did functional MRIs after the fact, or just regular MRIs. And those who did not wear it were found to have deeper tissue involvement in transmission of electrical nerve signals, so in that white matter region. So 73% of the individuals who did not wear this had that change in nerve activity. Whereas our group who did wear them, 77% did not have any of those significant changes in the white matter activity. So I have not seen this really on the market yet. I think they're still working on getting the logistics of it figured out, but it is something to consider, and it's something that may be on its way out here. They are talking about making it over the counter, so I think when that happens, we may just have to be careful about which ones are legit and which ones are not, because, you know, it does sit around your neck, so it's just, yeah. But it is something that they are working on getting patented and sent out for future use. I am not going to be able to say all these myself, but there's a list there of several supplements that have been looking at, that research has been looking at in concussion prevention. Some of these are simple ones that, you know, our kids should be taking anyways. So vitamin C, D, E, yeah, our kids should be taking multivitamins. Why not encourage them to take these that could help prevent concussions potentially? Same with omega-3 fatty acids, encouraging a good diet, making sure you've got plenty of those. But like I said, they've done some promising animal studies, but nothing currently on humans that I've seen that have shown significant effects. But we'll see what comes of that in the next couple of years. It shows some promising evidence. And then we've got some biomarkers. So the idea with this is, how awesome would it be to be able to walk into the ER, get a blood test, and say, hey, you've got a concussion, hey, you don't have a concussion. Or even like a point of care test. You walk into the pediatrics office and they've got a little finger prick blood test. Hey, you've got a concussion, hey, you don't have a concussion. And that's kind of where the research is heading right now. Is can we come up with a way to kind of establish this with these biomarkers to determine, one, if you're at risk of getting concussions, if you're more susceptible, two, if you have a concussion, and three, if you're at increased risk of having prolonged symptoms. And those are our kiddos that we have issues with, right? They have those prolonged, protracted symptoms. They may need to be referred earlier to have a little bit more intensive therapy. So it'd be really nice to be able to identify those kids. And Dr. Keel actually shared some research with me where they looked at whether or not ER physicians were good at essentially determining whether or not kids or adults will have long-term symptoms from concussions. And the sensitivity was something like 10% or something like that. So, I mean, none of us are great at determining like who is going to have these prolonged symptoms. So it'd be really awesome to have some biomarkers to help with this. So you have a couple up there, the apolipoproteins, glial fibrillary acidic protein showed some promise in one of the studies. CK, cortisol, all those things would be really helpful in order to talk about being able to evaluate concussions. This is a slide by Dr. Keel is looking at some of our biomarkers here, and as you can see, you've got your acute point of injury, recovery, post-acute, and and then you can see kind of how they've been tracking, and some of these biomarkers have increased over time, and ones that you can kind of trend and see which ones can progress to a little bit more long-term symptoms. I'm going to leave a little bit more of that to Dr. Keel if he wants to come chat with us, since it's more of his area of expertise. But just there's lots of promise there and good things coming our way. So, and then we got functional MRIs. These are a little bit more expensive and not as easy to use, but we do have them. It's been previously performed in adults, and again, they just kind of generalized it to kids, said, hey, kids are little adults, it must be the same in kids versus adults. And what they found in adults is there's not a significant difference between the healthy and the concussed adults, and that like kind of functional memory that's going on when you measure that in the MRI. But they decided, hey, let's study this in kids, and lo and behold, there is a large difference in kids and are healthy and concussed. They've seen some significant differences on the functional MRIs between the two. So overall, there have been functional alterations in brain activity between the two groups. So again, could that be helpful in diagnosing a concussion in these kids? I don't know how feasible this is going to be. MRIs are already expensive enough. I can assume that a functional MRI is probably even more expensive, but it is something that they are looking into as a potential diagnosis for our kiddos. All right, so that was a lot of talking. So I have a couple questions for you guys here from prep, but I'll kind of read through them, we can chat. So you have a 14-year-old adolescent boy being evaluated for persistent symptoms after he sustained a concussion while playing football. He was tackled during a game, hitting his head against the ground with loss of consciousness for an estimated 5 seconds. He immediately complained of headache and vertigo and was removed from play. Head CT performed at that time was normal. Over the next 3 months, he complained of persistent dull headaches, intermittent vertigo, insomnia, moodiness, had trouble focusing in school. Grades were falling, which he attributed to feeling constantly in a fog. Before his concussion, the boy had episodic migraine headaches, which occurred infrequently and responded to ibuprofen. There was a family history of depression, and the patient had seen a counselor a few years ago for some anxiety symptoms. At this visit, he is wearing sunglasses. He is alert and answering questions appropriately, but appears disengaged. Notable neurologic signs include difficulty with recall of 3 objects after 5 minutes, performance of serial 7s, and tandem gait testing. Of the following, the element of his history that predisposes him to this presentation is A, family history of depression, B, first-time concussion, C, history of anxiety, or D, immediate post-injury symptoms. Yeah. I'm hearing a couple C's.
D.
D? Okay. So it is D, so history of anxiety, like we kind of talked about before, some of these kiddos are a little bit more predisposed to those prolonged symptoms since they have some of those symptoms at baseline as well. So I think, again, those immediate post-injury symptoms can sometimes be helpful in determining if they're going to have worsening symptoms, but it doesn't necessarily predispose him to longer term. So question 2, we have a 16-year-old basketball player is being evaluated for persistent dizziness. 1 week ago, she collided with another player during a game. She continued to play, but within minutes developed a significant headache. She was diagnosed with a concussion in the emergency department and was advised to rest for several days and follow up with her primary care physician. Currently, she is feeling markedly better, other than persistent dizziness and a sense of being off balance, particularly with positional changes. Her physical exam findings are notable for provocation of dizziness with head movement and position changes. Neurologic findings are otherwise non-focal. The remainder of her exam findings are unremarkable, including full and pain-free range of motion of the neck. Of the following, the best next management step for this girl would be A, computerized neuropsychological testing, B, continued rest until symptoms resolve, MRI of the brain, or D, referral to vestibular rehab.
Continued rest, I'm not going with, because we were talking about to do that. The imaging, I'm thinking A or C.
I think A, you're too late to do, because those are really validated in the immediate
Yeah.
injury. So I would do C, just because she has some red flags.
D. So D is specific though, and they said not to refer to the specific place, like you should just refer to the brain.
I'll refer to the brain. That's what they're gonna do.
Yeah. It's like the more right, wrong answer.
That's what I'm gonna stick my neck out. That's what they're gonna do. But I'm with you for the Brain Institute.
All right, so the correct answer is refer for vestibular rehab. I think you guys kind of touched on the money. The computerized neuropsychological testing may be helpful, but it's a little bit more helpful immediately after in determining where her symptoms are. Continued rest, we already said, is not really the recommended role here. And then MRI of the brain. The red flag symptoms, I think, are a little bit more in that like first 48 hours when you're worried about bleeds or fractures or anything else like that. So your referral for vestibular rehab would be where you need to head next. And just to clarify, the referral to the Brain Injury Center is just for Carilion only. So if you're out in your own world, referring to those individual sports medicine or neuropsychological testing would be the place to go. So just a heads up for that. My resources. Any questions that anybody has? Yes,
Can you
Dr.
talk
Jacqueline.
at all, because there's some discussion about NSAIDs and Tylenol and the roles that those should play, relative frequency of use. I feel like those things change a lot, so while we're talking about it.
So basically what is kind of to err on the side of caution, you can avoid NSAIDs for the first 48 hours. Once you've kind of ruled out that there's no red flag symptoms, not really an increased risk of bleed, you can kind of move more towards those NSAIDs. That's being a little bit more conservative. Some people say that, yeah, you can go ahead and do it. But I would say probably the first 28 hours, or 48 hours, I'd still go with the Tylenol. And then they actually talked about Excedrin, especially after you're out of that like acute phase, can be really helpful. The caffeine is actually a little bit helpful in preventing some of those symptoms as well. And then again, if you're going into those prolonged symptoms, there's talk of using things like SNRIs and then like triptans for headache prevention as well for those kiddos. Which hopefully at that point you're referring to our injury center, but it is something to consider if you're going out into the real world and not the Carilion bubble.
So, good presentation. So, CDC as well as mild traumatic brain injury force has published its guidelines in 2018, which has definite definition. And I think the referral which you put has that's almost the definition for mild brain injury. As well as they tell when to do CT, they don't recommend MRI, they don't recommend biomarkers, and when to do neuropsychiatric evaluation, all those. So I think it's published in JAMA 2018. Mm-hmm. So if anybody wants to read that.
When they're going back to school, I've filled out lots of these school forms, like the extent of cognitive rest and things. Is there any update or anything that's different recently in terms of what we need to do to tell the school?
I haven't seen any significant updates about that. The biggest things I talked about were the 504 plan and IEPs if you're having like those prolonged symptoms. I didn't see as much about like the academic portion of school. They talk a lot more about like return to play and stuff. But again, I think it's kind of similar things where if they're able to kind of push through and then taking those breaks throughout. So maybe doing like 1 or 2 hours at a time and then having that time where they can go sit at the nurse's station or have those scheduled breaks so that they're not working that brain as hard can be helpful in those kiddos. I don't know that that's necessarily new data, but that is kind of what they've talked about in a lot of the research is helping with that.
What I've seen done in terms of that is like, rest as needed for schoolwork, but can't progress through the return to play until they're doing full return to schoolwork, and then no testing that would impact their future until they're at that full return to game play.
Yeah, and they did talk a lot about like not doing those standardized tests while they're recovering from concussions, so trying to work with the school to help with that and rescheduling of those.
It seemed like there were a lot of conversations a couple of years ago about that we're very focused on return to play, but the academic and cognitive impact was much more than people had initially anticipated and ended up having lifelong consequences.
Yeah. It can be very stressful kind of coming back from that work, especially if you're falling behind, and then they technically ask the teachers like, hey, maybe don't give them as much work, but then you're also running into the fact like, hey, you're not getting as much work, you're falling behind because you're not getting as much education as your peers.
I think these kids are ones that you shouldn't be afraid to have those frequent follow-up visits, right? Like, hey, I'll see you back in 3 days. I would expect you to be at full academic progress at that day. If we're not, right, like this is very odd. And so I typically will see these kids back, like scheduled, I see you, I'm gonna schedule you for the next 10 days, like, 2 or 3 follow-up visits, just to make sure we're not missing that, because especially for those ones who really aren't like, I knocked my head, I have a little bit of a headache, that you have a better idea with my 10% sensitivity that they're not gonna have prolonged symptoms.
Couple comments, more than questions on that. Very nice presentation. And you packed the house relatively, so I want to thank you for doing that and for the folks at Tangle that are there. Those that might be in the neighborhood but didn't make it down, unfortunately missed some lively rapport which you've had this morning, and I encourage everybody to keep coming. Damon Keel, the first time I heard him talk about it, I don't know about the biomarkers or not, he's doing the research on it, it's amazing, and so I would encourage us to maybe, if he's willing to do a talk, bring him out, if you ever have a chance to listen to him. And you mentioned the Virginia Tech Helmet Lab. One resource they have online is they have ratings of helmets You may have student athletes that are interested, but it's amazing. And again, if you ever have the opportunity to visit there or speak with the folks that do that, it's amazing. They got these like little tiny accelerometers and all this in the helmets. For those of us that are weird engineering background, love that. I'm going to do a plug for pre-participation. You mentioned the PCPs. As you all know, they also, these student athletes go elsewhere. They may end up at Velocity Care, which I think is probably doing a respectable job, but some of the pop-up sports physicals, I know we like to see them for their well check, but keep an open mind on doing these, because I've been on calls with the athletic directors of the school systems, and quite often they'll say, well, all they need is a signature. And I bite my tongue very hard. And so, anyway, so think about why we want the PCP, think about doing that. And if I rambled, it's because my sport was not on there with my concussion. Fishing didn't make your list. And on that note,
What are you doing out there?
I wasn't drinking.
Big fish, caught it, right?
The waters are pretty
We'll
salty.
take that discussion offline.
Any questions online? All right, I'm going to thank Dr. Price for an excellent presentation. Thank you.